7 ஆயிடுச்சு.
Yes, ma'am. We are live now, ma'am.
Good evening, everyone. A warm welcome to everyone who has been attending this AKSHARAM series and who are also attending for the first time. It's one of the most important projects of our President, Vijaya Madam, and our Secretary, Geeta Lakshmi Madam, because this is a combined effort of OXY Medical Education Committee and FOXY Medical Education Committee. It's a webinar series, and we are very happy to say that we are in the 10th episode of this series. And with our new President, Sunita Madam, and our past President, Dr. Jaideep Tank, and with the blessings of our Medical Education Committee Chairperson, Dr. Kiran Pandey, we are able to continue this session, and we are very happy about it. Today, we are going to have a talk on cardiac disease of pregnancy by the eminent cardiologist, Dr. Justin Paul. Next slide. I request Dr. Vijaya, our President OXY and Chairperson of the Medical Education Committee of OXY, to give her welcome address. Vijaya Madam is a professor and HOD of ESI Medical College, KK Nagar, Chennai, former director of IOG Madras Medical College, and Madam has lot of special interests and credits. And she has got Best Paper Award in AACOG 25 and Best Doctor Award from Honorable Health Minister of Tamil Nadu. She has a lot of publications to her credit. Over to you, Vijaya Ma'am.
Good evening, everyone. This is one of the, every month, the most important day I look forward is this AKSHARAM series day. So when I took over as the president, I was just thinking, one second. I was thinking that we should do something for the students and young consultants, and it need not be a panel discussion or too many speakers. It is one topic and one speaker, and they will cover from the beginning to the advanced. That is what I was thinking, and then it has been going really well. And every month I really take care and think so many times to choose the best speaker. And every time, every conference, I will ask who will talk this topic, who will talk this topic, like that. The next month I will be before 2 months only, I will start planning for that. And today's topic is very, very important, the cardiac disease in pregnancy. So much has been advanced, and all the cardiac disease patients are now becoming pregnant, and even myocardial infarction and older age group also after IVF, we are seeing so many patients. So this is today's important topic, and who can be a better speaker other than Dr. Justin Paul. When he comes, we will be talking about Dr. Justin Paul a little more, and I welcome all of you for this AKSHARAM series. Karpagam.
Thank you, ma'am. Now, we always start our program with the lighting of the lamp. Now, we always have our prayer to Goddess Saraswati, our invocation for any program. We will do our duty. God will definitely bless us. Thank you, Sahiti. Now, I welcome Dr. Geeta Lakshmi, who's our Secretary of Oxy and also Associate Professor at Government RSRM Hospital and belonging to Stanley Medical College. Madam is a UG and PG teacher for many, many years, member of Chennai Menopausal Society, SOFC and ISOPAP, presented papers in various national and international conferences, and her areas of interest are high-risk pregnancy, adolescent health programs, and medical education. Madam will be rendering the Oxy prayer.
Thank you, Karpagam, for the kind words. A very good evening to everybody. Good evening, Dr. Kiran Pandey, Madam, Dr. Vijaya, and Dr. Karpagam, and today's eminent speaker, Dr. Justin Paul. So, with the blessings of the Almighty, we shall start this session on Aksharam series. So, I go on with the Oxy prayer. Thank you, God. In humility, we gather. In gratitude, we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. So with this, we will go on with the Aksharam series, and today's topic is a very important topic, cardiac disease in pregnancy, not only for the postgraduates of OBG, but also for the postgraduates of medicine and cardiology. And I hope they also have joined, and they will definitely be benefited with this. Thank you so much.
Now I request our President Vijaya Madam to introduce our guest for all times, Kiran Pandey, who is the Chairperson of Medical Education Committee of Foxy.
Good evening, Dr. Kiran.
Good evening.
Yeah, good evening. Very nice to be with you, and you are with us from the beginning of this Aksharam. And this is the 10th episode, and today I have sent you the message. It is an important topic of cardiac disease in pregnancy. And Dr. Kiran Pandey is the chairman of the Medical Education Committee, and she is my inspiration from whom I thought I should also put Oxy into this webinar series. And Madam always encourages us, and she is the chairperson Medical Education Committee and professor head of the department of GSVM Medical College Kanpur, and she's the past president of COGS and IMA, president UP State chapter AGY 2024 to 2026, and she has got more than 36 years of teaching experience, and she has organized many workshops and organized organizing secretary in so many conferences, and also now this recent menopause conference, which is to be in February. Madam is the key person, and so much of activities going on in Kanpur, and Madam has got lot of research activities and awards to her credit. Dr. Kiran, over to you, ma'am.
Thank you, Dr. Vijaya. Thank you very much for the very, very kind words. And it's really very heartening to always see you and your people, Karpa, Dr. Geeta Lakshmi, and everyone so enthusiastic about the program. And that you select always gems of the person from the whole over the India. You take out Dr. Justin Paul, who doesn't know about his caliber and his commitment to the cardiology. And we all know the cardiac problems in pregnancy are very, very important. There was a time when these patients were not surviving at that till the age of pregnancy. But now, with the most of the advancements and in the techniques, in the instruments, in the skills, and everywhere, these patients are surviving a good amount of it. Even the rarest of the rare disease, people are able to save that, and the credit goes to cardiologists and cardiac surgeons, and of course obstetricians. So we are always the in between of that, and we are always concerned not only with the patient, with the baby also, because both are our, I mean, we want to that the patient should go happy with the taking the baby. So the good news remains. Very important issue for the students, postgraduates. They usually get these cases. Dr. Vijaya is, I mean, she's a very good eye for that. Selects always those cases which are really good for postgraduate exams. So that's a very important thing, because it's very important for them. I don't, without wasting time, I would definitely like that the discussion starts, and we don't want to miss a slightest of the time of the Dr. Justin Pai. The only thing I just want Vijaya to, and Karpa, in fact, actually Vijaya is so busy. Karpa, you please take care that our president have changed. Dr.
Yes.
Sunita Tendulkar,
We have
Yes,
put
yes,
that,
madam.
yes, yes,
as
Valid,
madam.
madam.
General
We have changed,
Secretary.
madam. We have
We
changed.
changed.
So,
But I
yeah.
didn't
So,
put it in the WhatsApp group, but we have changed just now. Yeah.
yeah, Secretary General Dr. Suvarna.
Yes,
So,
Suvarna.
of course, Dr. Jaideep Tank, this was started with the permission of Dr. Jaideep
Yeah.
Tank. He's always there.
Yeah.
But Madam is
Yeah.
definitely, and
Sunita, ma'am.
she's very and also enthusiastic, encouraging. The various projects have come. I mean, I think every day packed will be the
I
academic.
know. Academic calendar. Yeah.
Yes. So let's hope, because that will be.
Maybe
In
next
my
time we'll
report, I
try to
would like
call
to
her.
use.
Yeah.
In my report, I would like to use the latest
Yeah.
one.
No
So,
problem. Yes.
so thank you very much. And Vijay, we are going to miss you, although Karpa is coming.
Yeah,
So
yeah.
that's and I mean Chennai team is also big. Chennai team is coming, and I hope you have all have taken your flights, booked your flights, etc.
Yeah. Everything is done, madam. We are around 9 of us.
Why? I tell you why. Just a second only. I'll take a minute. I got a heart attack this today almost. There are now the flights are costly because of Kumbh.
Kumbh Mela.
70,000,
Kumbh Mela.
76,000.
Kumbh Mela.
Yeah, so I was so shocked and depressed. How the people will come? So I'm naturally now worried that my all the close persons should be there, if they booked or not. So that's the thing.
We booked long back, madam. 9 of us have booked it.
Thank you. Thank you very much.
Okay.
Okay. So please go ahead, and all the best for this webinar, and I'm there.
Okay.
Yeah,
Thank
we
you.
also feel very happy to see you every month, madam.
Thank you. Thank you, Dr. Geeta Lakshmi. Thank you so
Thank you.
much.
Thank you, ma'am.
Thank you.
Okay.
Karpagam.
Yeah.
Sarah join.
Yeah, Sarah's joined.
Welcome, sir. Good evening.
Good evening, ma'am. Good evening.
Hi,
Good evening.
Justin. Good evening.
Good evening. Good evening.
Now we'll go on to our teaching session. Now we have the most important topic, cardiac disease in pregnancy. And as madam said, we have a lot of new developments and management techniques, both cardiac wise and also obstetric wise. And I would like our president, Dr. Vijaya madam, to introduce our chief speaker for the day, teacher for the day, Dr. Justin Paul.
Yeah, very, very happy to welcome Justin to our obstetric world because he is a professor at Madras Medical College, the prestigious Madras Medical College, Institute of Cardiology. And we were all together when he started the pregnancy registry, Tamil Nadu Pregnancy and Cardiac Heart Disease Registry. And so much trouble he underwent. I know every day he used to go to NHM and he will be talking to higher official to start this registry. That was one of the feather in his cap. And he has been adding lots and lots. Now he has started Cardio Obstetrics Society of India. How nice it is. We all are members in that. And only after this registry has started, so much of data about the heart disease in pregnancy has come into, and even European Journal of Cardiology, this paper is there, and also almost all the conferences, Justin Paul's paper will be cited. How prestigious it is to have such an young age. And I welcome Dr. Justin, and he has initiated the field of cardio obstetrics in India. He is the course director of cardio obstetrics master class, and he has published more than 100 international and national journals and research grants of more than 10 crores. Can you imagine? From ICMR Imperial College London, and welcome DBT, and Best Doctor Award in from Government of Tamil Nadu 2018 and 24, and Excellence in Research Award Madras Medical College 2022. Welcome, Justin. We are so happy to be associated with you. And on the top of that, he is the student of Tirunelveli Medical College, and I was his senior, much ahead than him. So that connection is also there with Justin. Welcome, Justin.
Thank you, thank you, ma'am. Thank you. Thank you, senior members of Oxy and Foxy. Can you hear me? Am I audible?
Yes, sir. Yes. Please, others, please mute here. Please mute.
Nefi, mute.
Sir,
Yeah, good evening, all of you. My sincere thanks to the Foxy and the Oxy, and in particular my senior, Dr. Vijaya, for having called me to speak in this session. Thank you so much for the kind words that you have spoken about me. So I will not waste much time, and we'll just go into discussion on this. The plan I'll be talking to you is why we need to focus on our heart diseases in pregnancy. And it was too broad a topic, so I was not too sure, what exactly to talk. Because sometimes we have that. In fact, there is a program called Cardiac Problems in Pregnancy. It happens for 2.5 to 3 days, once in a year across international destination. This year it is happening in Austria. If any of you would like to attend, all the big names of cardio obstetrics across the world will be there. So we are also there. So, however, I am just giving some tidbits. The first thing is the importance, why we need to give importance to this field in this country. And maybe depending on the time availability, I'll be sharing to you about some of the high-risk conditions which we felt people should be aware of. Now, if you look at the number of women dying during pregnancy every year, this is a little bit older data. On an average, about 35,000 women die every year in India, and almost 12 to 13% of all mothers dying during pregnancy are from India. As you can see that the number of mothers dying is coming down across the world as well as in India. And if you look at very specifically, the number of mothers dying per year, India is only next to Nigeria. If you look at the number of mothers dying per year in China, this is about 5-6 years back. For the similar population, only about 1/7 of our numbers, 35,000 mothers in India in 2017 and only 5,000 in China. So we really need to focus on coming down. We cannot be satisfied that we are better than Nigeria, but we need to, improve on this particular area. And though Tamil Nadu, Kerala, we have achieved the SDG goal for MMR of 70, India as a nation, we are yet to achieve the Sustainable Development Goal given by WHO for MMR. So these are some of the states that are really lagging behind, and we have done well thanks to wonderful people like you. Now, if you look at the maternal mortality in India, the attributable causes, if you find bleeding and sepsis contribute to more than half of it. If you look at MTPs, it adds almost 2/3 of it. What is happening in the West? If you see the causes of pregnancy-related death in UK, cardiac diseases is the #1 cause of maternal death in UK. This is the Embrace database, and this is from the US. As again, you find the heart diseases is the leading cause of death. This is a later data from US. If you find cardiovascular conditions, cardiomyopathy and thromboembolism contribute to 1/3 of all mothers dying in US. So every third mother who dies in US is because of a heart disease. So thus in all developed nations, you find that heart diseases are the #1 killer of mothers during pregnancy. So why this is happening? This was introduced, this concept of obstetric transition was introduced in 2015, where nations, as they improve from a high maternal mortality and high fertility rate to a lower maternal mortality, as the general development improves. From stage 1, you can see MMR of more than 1,000. Very few nations in Africa, unfortunately, are still in the stage. And stage 5 is a stage where we have an MMR very low, less than 5, and 5 maternal deaths per 1,000 live births. So we are rather sort of into stage 5, in and out of stage 4, and Kerala is in stage 4. And most other states of India are in stage 3 of obstetric transition. If you look at the cardiac, what is happening here is that the direct obstetric causes are coming down. Why? Because of the hard work by the obstetricians. You have done so much to control the deaths and the complications related to bleeding and sepsis, obstructed labor, all that. Indirect causes are an increase, of which heart diseases are going to be the #1 cause of maternal deaths. And this is what I told you, from a nation develops, this phenomena is called obstetric transition. Now, this is really happening in Tamil Nadu. I've shown you. This is the data collected thanks to the National Health Mission. In 2011 and 12, we had 834 maternal deaths, of which 38 were cardiac deaths. And as you can find that the cardiac contribution to MMR was 4.58, MMR was 90. If we come down to 22-23, it is almost scaling to 10%. So from 5% cardiac contribution, the contribution has gone to 10% now. I'm sure it is going to increase to 15 and 20%, though MMR may come down. If you look at the number of mothers dying is coming down, but the number of cardiac deaths remains the same. And this is the reason for the increase in cardiac contribution to maternal deaths. Why is this happening? If you look at that, many heart diseases are now detected in utero. And school health programs are very efficient. And as a result, certain heart diseases, patients are where we find that they cannot be healed. They are managed well, different aborted, and those ones we have in neonatal or in utero balloon aortic valvotomy and fetal cardiac interventions have started. And neonatal interventions, pediatric cardiology has developed leaps and bounds that so many children who would have otherwise withered with the wind now survive to childbearing age, and they have a dream of becoming a mother. So it becomes our responsibility to support them and encourage them in their dream so that they have the joy of being a mother. The improved diagnosis and management, as I told you. The other aspect is, as the society also undergoes a transformation, the marriages are getting late, the first pregnancy age is becoming more and more late pregnancy, poor lifestyle habits, and more women come with increased cardiovascular risks. Smoking women, women with hypertension, women with diabetes, women with obesity, women with heart attack, women with the bypass, women with the PCI, we are seeing them more often now. So as a result, we get more women with heart disease coming to pregnancy, unfortunately at a time when the system is not really ready to manage these high-risk women. So obstetric care is improving, as I told you, early booking, management of anemia, undernutrition. Whereas here, as I told you, we are still not able to manage. So we have not been having focus on this particular area. Thankfully, we are doing better now. This is one data from United States from the 9 counties evaluation, where they identified all the maternal deaths and classified them as preventable and non-preventable. Of the preventable cardiac deaths, the cardiovascular deaths, 68% of all heart diseases leading to death during pregnancy could have been prevented by any alterations in the management or the care pathway chain. You can imagine 68% of all mothers, maternal deaths could have been prevented in the US. What do you think will be the status in India? We don't really have a confidential inquiry in maternal deaths going on across the country. It started in Kerala in 2003 after the WHO work, but then, we are yet to start in most other states and across the country as well. So we do not know what percentage of cardiovascular deaths are preventable. but I'm sure this is likely to be more. This gives us a phenomenal responsibility of doing something about that we prevent these preventable deaths. These remediable causes need to be identified. So as I told you now, the summary is that in the last line, heart disease will be the single largest cause of maternal mortality in India very soon, 5 years, 10 years, or 20 years down the line. How fast we are improving our overall health program, this is going to be the leading cause of maternal death. Why is that? The management pathways are not often known, not often clear. Data is not very strong. And many are not keen on developing their knowledge base in this field. If you look at both obstetricians and the cardiologists, this may not be a financially rewarding field. Cardiologists will be very happy to do, structural interventions, putting an aortic valve or a mitral valve through the leg, or, will be like happy to put a stent. It'll be challenging, and we can presenting this. For the obstetricians, maybe, in vitro interventions or, this IVF, all this stuff, you may be more interested in that. So less rewarding, less, attractive field. And lack of coordination, the need for coordination is yet to be fully understood. We all live as individuals and treat as individuals. Okay, you see the cardiologist and come, cardiologist will write something. Okay, you meet the anesthetist and come, then they go. Then finally, no, you go back to the cardiologist. The patient runs around and there is lack of coordination. And the awareness of this need is lacking among medical officers, administrators, funding agencies, public media, everywhere, and paucity of our own data, our own guidelines. So we need to focus on this particular area. I also would like you to think of the patient's burden. When a patient comes to you with a heart disease, as comes to me with a heart disease, is told that you have a very serious heart disease. She has a longing to be a mother. She also fears that if I continue the pregnancy, I might die. And the mother-in-law, father-in-law, the in-laws family suddenly realize that the daughter-in-law that has come into the family has a heart disease. So the lot of mistrust and domestic violence is on the rise. The patient is really not sure whom to trust, whose word to trust. The husband, the mother, mother-in-law, daughter-in-law, father-in-law, the doctor or the nurse. A non-supportive healthcare, which is already overloaded. And the doctor's burden, what happens if the patient dies? How many reviews I will have to attend? Will I be having a comfortable review or it will be a harassing review? And there is no big team to fall back to support on. I don't know what to do at this point of time. Who will help me? Am I right in the management? These are all the issues that doctors face through. And, if you look at this patient, oh God, each one will have their own thoughts. At the end of the day, what we call as a not my baby phenomena really works here. But the patient has their own baby. All of this we feel that, oh my God, okay, that the man somehow not call me. In this background, symptoms, stress, anxiety, marital conflict, fear, mistrust, lack of support, abuse. You may be surprised. So much of domestic violence I come across. This is just a very small study. I have not published because I have not taken the ethical committee approval. I cannot publish this. About prosthetic valve, the first 17 patients I saw, they had 48% as verbal abuse, 19% physical abuse, marital separation, social isolation. So these women are really so pathetic and they really need to be supported well. So with this kind of passion that, we started the Madras Medical College Pregnancy and Heart Disease Registry, of which we can see that we published it. The last author, as you can see, that is Dr. Vijaya. And we collected a lot of cases. This was, this generated a lot of a passion that I've been seeing these mothers dying down like sparrows. It is so sorry state of affairs. And we just collected the prospective data of 1,029 pregnant women pregnancies. So, of which 683 had acquired heart disease, predominantly it was rheumatic heart disease. We also had cardiomyopathies and mitral valve collapse and some congenital heart diseases as well. Most a third of them were congenital heart disease, of which left to right shunts predominated. Almost 75% of them were left to right shunts. If you look at another surprising finding we had was many women, the heart disease was diagnosed for the first time during pregnancy. About 60%, of which half 50% were during present pregnancy. Majority of them were minimally symptomatic, but however, about 10% of them were NHA class 3 or 4 at the time of presentation. Most of you will be familiar with the MWHO classification. We'll see that very soon. But if you find that our data, all of them are sort of equally distributed. The surprising thing was, we were trying to coordinate well with the obstetricians there at Madras Medical College. So the patients with the heart diseases, the cesarean section was only 39%. But at the same time, without heart disease, the cesarean section rate was 46%. This is a surprising good information of outcome out of coordination. So when we focus on managing these patients well, many of them could be nicely delivered by vaginal delivery. And we had some kind of cardiac event in 156 patients, of which heart failure was the most common event. If we look at the attributed causes of death, prosthetic valve thrombosis, this was, my God, so much could have been done in this area. 6 of these 20 women died due to prosthetic valve thrombosis. And heart failure with reduced ejection fraction was the next following. So almost 55% of all the deaths were either due to heart failure, reduced ejection fraction, or prosthetic valve thrombosis. If you look at the risk predictors, we found 3 of them predicted maternal death. The second row, as you can see, is maternal mortality. Pulmonary hypertension, the mortality rate was 4.8%. Prosthetic heart valve 8.6%, LV dysfunctions 1.9%. They all predicted death. In addition, overall outcome, mitral stenosis and current pregnancy diagnosis. If diagnosed for the first time during pregnancy, what happens is you are not really able to manage them well, and the disease is not optimized before pregnancy, the complication rate increases. This is one of the comparison of the 3 largest registries available in the world now. Thankfully, our Madras Medical College data is now compared with ROPAC registry and the CARPREG registry, the other 2 large registries. Of course, ROPAC was conducted in 58 countries over a large period of time and 5,700 patients, and CARPREG was in Canada from 2 states, two places. As you can see that our patients, majority of them were current pregnancy diagnosis. 50%, whereas in the ROPAC, only 8% were current pregnancy diagnosis. CARPREG did not have this data. If you look at the type of heart diseases, CARPREG, 63% were congenital heart diseases, whereas our side, only 33% had congenital heart diseases. Now, and in the ROPAC also, 57% are congenital heart diseases. Now, most of the guidelines are from ROPAC and CARPREG. So if you think of that, the population that we deal with and the population the guidelines dealt with are completely different population. Those guidelines may not be really applicable to our Indian population. And this was another comparison, the same thing, as you can see that our maternal death rate was very high, 1.9%. Whereas the maternal death rate was 0.5% in the other 2 registries. We had a high equivalent heart failure complication rate. So, higher proportion of high-risk heart diseases we had. MWHO 3 and 4 were very highly represented in our population. So, another outcome, we looked at the pre-conception data. 232 of the congenital heart disease patients were eligible for preconception because they were diagnosed before pregnancy, of which 53 had some kind of preconception counseling. Whether when we said preconception, we included pre-marriage, post-surgical, post-marriage, before conception, all these 3. And what we found was These are the various types of counselings. Those who had a preconception counseling, as you can see that the cesarean rate was low. The maternal cardiac event rate was low, but this was not statistically significant because the event rate was less, 3.8 versus 7.4. If you look at the fetal outcome, was statistically significantly better in those with the preconception counseling. That talks about the importance of preconception counseling. But then what kind of counseling we provided, we also looked into that. Well, this is the result in a higher proportion of vaginal delivery, lower fetal event rate, and lower maternal event rate. Those who have a preconception counseling. So we really need to start preconception clinics in our places. What kind of counseling we gave? If you look at that, appropriateness of MTP advice. MTP advice is so rampant that, even patients who could otherwise comfortably go for pregnancy are advised medical termination of pregnancy among congenital heart diseases. Of the 22 MTP advices, only 11 were appropriate, and half of them, the patient need not have been given MTP advice. And many primies were given MTP advice when MTP was not warranted and the patient could have, comfortably continued pregnancy. 1/3 of them, after delivery, were not even given any contraception counseling. If you look at the appropriateness of preconception counseling, before conception, for MWHO class 4, there is those with very high risk heart diseases, 3/4 of them did not even have any preconception counseling. And of those who had, 25% of them were advised to continue pregnancy even though it causes risks to the mother. So these were the take back from our database that heart disease being diagnosed for the first time is very high, 60%. And presence of a mechanical heart valve, presence of LV dysfunction, and presence of pulmonary hypertension predicted death. So we identified that there is a lot of lacunae in coordination. So we felt a trained cardio-obstetric care and a coordination will improve outcomes, and every nation has to develop its own regional database and customize care accordingly. This is our conclusion that we publish in the impact data. Taking it up, we extended it up. So where are we now in India? I think I shared this slide already with you. I'm sorry because I've just mixed up all those slides just today and tried to give a combined data. I'll just follow the same trail and just allow me to get back to the slides. Yeah, fine. Following the impact data, we went ahead collecting the Tamil Nadu Pregnancy and Heart Disease Registry. I should really thank the government of Tamil Nadu, National Health Mission, our MDs, Dr. Daras and Dr. Senthil, who really helped me in getting a cardio-obstetric group formed in all these 29 participating sites. We conducted orientation meetings and we particularly focused on anticoagulant management in prosthetic heart valves because in the impact we found that was the biggest cause of death. And 2863 patients were enrolled. These were the participating sites and the enrollment data. We are yet to publish this, but we presented this as a late-breaking science in the European Society of Cardiology Annual Congress at London last year. Here again, you find that almost 50% of the diagnosis the first time, and congenital heart disease is on the increase. What was 33%, now it's around 45%. So one of the changes that is happening in our country is that the proportion of pregnant women with heart disease, more of them are becoming congenital heart disease. So we have to be trained to manage congenital heart disease becoming pregnant. Just like, I told you, we are becoming like the developing nations where the congenital heart disease predominates. And mode of delivery, cesarean was 52% this time. What you found in MPAC was 39%, here is 52%. And the fetal outcome, this was our fetal outcome. And maternal mortality was lesser here. Maternal complication rate was 11%. We could have missed minor complications because it was COVID-19 was ravaging during the follow-up period. And 44 maternal deaths. This time, majority of them were due to peripartum cardiomyopathy, pulmonary hypertension, rheumatic heart disease, and heart failure. Prosthetic valve thrombosis deaths were less. The commonest causes of death were these three, and majority of the deaths were in the postnatal period. 86% of all the deaths. So it's very important that after the delivery we need to focus on giving time to the patient to see that they are safe walking home, and after discharging them as well, we need to keep them on close follow-up. So this was a data. We looked at what is happening to these patients who continue pregnancy against medical advice. In our registry, 82 women were advised against pregnancy, of which, as you can see, that MWH4 of the 350 patients who were advised against pregnancy, only 41 chose to continue pregnancy. And surprisingly, in MWH 2 to 3, as you find, a majority of them were advised against pregnancy, which ought not to have been done, of which 12 continued pregnancy. As you find that here, those who continued pregnancy against medical advice, against those who continued with medical advice, there is a significant increase in maternal complications. Those who continued against pregnancy, almost the death rate was 10%, while those who went ahead along with medical advice, the death rate was only 1.3. So it is very important that we support the patients and encourage them to follow medical advice, particularly MWH class 4, not in the other classifications. And here I want you to focus on this particular area, the predictors of maternal death in our multivariable analysis. The green color, I'm so happy because this time prosthetic heart valve was not a predictor of maternal death. We focus so much on anticoagulant management. We conducted orientation meetings that the care improved in this area, and it was no longer a predicted maternal death. But as you find that late pregnancy assessment and presence of severe mitral stenosis are predicting maternal death. Last time, mitral stenosis was not predicting maternal deaths here, but this time it was. The reason, in MMC, in the MPAC, we had done 17 patients who had significant mitral stenosis, antenatal balloon mitral valvotomy. Whereas here in these 29 sites, only 2 were regularly doing antenatal balloon mitral valvotomy. So I feel that the absence of antenatal mitral balloon valvotomy in many of these patients could have been tilted this into being responsible or being a predictor or associated with maternal death. So we need to improve the capacity of our system to provide antenatal balloon mitral valvotomy, because we get a lot of patients in different areas shifted to our place for antenatal balloon mitral valvotomy. We need to improve the locally available technology, build the capacity of this infrastructure, and they can provide good care there. Valvular heart diseases are predominating in the LMICs, whereas congenital heart diseases are fast catching up. And current pregnancy diagnosis is very common. Heart failure remains the most common adverse outcome during pregnancy. And these are the predictors of maternal death. Late pregnancy assessment is a predictor of maternal death. So it's very important we catch them early. How do we catch them? We really need to have good clinical evaluation. And if the system would allow, if you did not compromise the care of the rest of the area, routine echocardiography is fine. But if a routine echocardiography is going to affect or overload the system, that necessary echocardiography is going to be affected, we need to be very careful about recommending routine echocardiography. It is a luxury if we can afford, but then it should not compromise the care in the other areas. And this was a predictor of maternal deaths. So our conclusion here is that sensitization and training in cardiopstic team approach improved pregnancy outcomes in women with heart disease. So whenever physician and cardiologists sit over a coffee table, share a coffee or a snacks and discuss about a case, the patient's care improves. So please, obstetricians, wherever you are, catch your cardiologist, ask them to come to your place, or you go to their place and have a cardiopstic group in your center. And we also need to develop center of excellence for cardiopstics, particularly for early referral. Collect your data, publish your data, and develop local management protocol for a healthcare system. Now, taking this forward, we are developing a study across the country. Thankfully, ICMR has funded this 4-year study, which we just started last year, and we are into the first year of the study. The idea is to develop a care process protocol, how to develop a cardiovascular care protocol, and that India-based data, Indian protocol, whether it will improve the outcome. This is a mixed method study where we are doing a cluster randomization. As you can see that thankfully, except very few states, we have representation across the country, except say maybe a couple of places where we could not manage to get investigators who could form a local cardio-obstetric team. One of the criteria was that because in the locally they should be able to form a cardio-obstetric team. Some of the sites, they were far away. What is the ideal cardio-obstetric team? If you look at that, if you're a luxury of having all these people in your team, that is wonderful. But this may not be possible in most of the setups. So what we suggested that we have just published this last year in Indian Heart Journal about how to develop this in our nation, at least a pediatrician, an obstetrician, a neonatologist, and a cardiologist, an anesthetist. These 4 can join together to form a team. Though you at least you should develop, say particularly in an institution, if one obstetrician or 2 of them out of 8 are keen on this particular area, it is nice if everybody gets their opinion. And so the institution's care improves, that obstetricians particularly experience improves. And similarly, for a cardiologist who's willing to focus their time on this particular cases, the rest of them could refer. So you could find some way so that your institution becomes a good cardio-obstetric care institution. So this is the team, and we need to really work together from the preconception level to the long-term follow-up. So these are the areas that we can really make a difference for our patients. So let us focus on helping them. Now, cardio-obstetrics, why this becomes important. Now, if you look at the pregnancy, this is a very brief note for the postgraduates who are here. The cardiac output increases almost by 50%, which is contributed both by stroke volume and the heart rate. As you can see that the systemic vascular resistance comes down, but the cardiac output goes up. The cardiac output is predominantly contributed by the increase in plasma volume, followed by red cell volume. So as a result, there is a relative anemia of pregnancy. Now, what happens during labor? I had a couple of slides. I'll share that also. 1 minute, I'll share those slides as well. So, yeah, labor, I'll share those labor slides. This is also important for us to know what happens during labor. Am I visible now? The slides are sharing?
Yeah, it's visible. Paul, it's visible.
Thank you. So the maximum cardiac output associated with pregnancy occurs immediately, during labor and immediately after delivery. Cardiac output increase almost 30% the first stage of labor. Here primarily because of an increase in stroke volume. As you can see, with the Valsalva, with every pushing, the second stage, the cardiac output can increase as much as 50%. What is going to happen in a patient with severe pulmonary hypertension, where the lung pulmonary vasculature cannot expand? It has to handle this extra blood. It is going to be a big strain on the RV, and RV is going to fail. In a severe MS or in a patient with LV dysfunction, it is going to be a big stress for them. So laboring in sitting position or left lateral position or neuraxial anesthesia reduces but may not eliminate this increase. As you can see that, in this position, supine position, the vessels, IVC and the iliacs are compressed, whereas in the left lateral decubitus, there is a small decrease in maternal heart rate, a small increase in cardiac output. So if you can manage, this is fine. During the various phases of Valsalva, reducing Valsalva during second stage of labor is extremely important. This basic Valsalva physiology. Thus, a prolonged Valsalva can reduce the preload. In LV dysfunction, this can reduce the cardiac output. When the preload comes down, many preload dependent circulations like fontons or dysfunction, where the cardiac output, you need a decent preload. The preload goes down, patients are going to be affected. So we have to cut the short. And most of you are very familiar with that. You have to be careful about that. I should not be talking this to the obstetricians. Well, coming to the delivery, where do we deliver the patient? Should it be inside the labor room or delivery outside the labor room? Sometimes, we may have to have a planned delivery outside the labor room in high-risk cardiac patients, wherever they are. It's very important to have a critical care access and heart failure team, particularly IABP or ECMO, if it is available, they should have access. And patient, the cesarean who also require a cardiac surgical standby, cardiac surgical theater. Recently, we had a patient with a double orifice mitral valve and a severe MS and a patient in florid heart failure. So we tried to do a balloon mitral valvotomy. The patient developed a valve tear, heart failure. So we shifted to the cardiac theater, cardiac surgical theater. The physician came and we did a cesarean and delivered the baby alive. And then the cardiac surgeon took over and replaced the valve. Both the mother and the baby came out alive, but unfortunately, we lost the baby on the 40th day. So it's very important that we develop a system of care where we can coordinate. And the timing of delivery, we need to focus between the benefit of early delivery and the risk of prematurity. So vaginal delivery is recommended for most of the patients with the heart disease. The reason is, you have a gradual hemodynamic shifts compared to cesarean delivery, and risk of obstetric and surgical complications are lower. And most for the stable heart diseases, it is fine. What about cesarean delivery? Those who are on oral anticoagulants, if they develop labor with a high INR or aortic dissections and aortopathy, severe pulmonary hypertension, intractable heart failure, these are the clear indications for cesarean delivery. For most others, we can manage with labor delivery and labor analgesia. So, neuraxial anesthesia, of course, it reduces the systemic vascular resistance and mean arterial pressure. With the spinal, this can be very rapid. So, maintaining a maternal SVR and mean arterial pressure throughout delivery and immediate postpartum period is very, very crucial. So, gradual and slow infusion of anesthetic in small increment doses is better than a single bolus dose, because a single bolus dose can produce a drastic drop in SVR, which is going to be very detrimental for the patient. So what happens if the patient develops a cardiac arrest? So you need to have 3 teams, one on maternal resuscitation, one on obstetric care, and one on fetal care. Who is going to lead the maternal resuscitation? Who is going to provide the obstetric care, and who is provide the fetal care? And obstetric anesthetists are always a big asset in the high-risk labor wards. And if it is there in a mechanical circulatory support center, it will be always good. And IV access is always ideal above the diaphragm. And left lateral uterine displacement after 20th week will be helpful. And do not withhold any medications of ACLS for the concern of teratogenicity. Fetal well-being plays a second role now. This point primarily is maternal well-being, and no adjustments of ACLS medications are required. And routine standard defibrillation techniques are fine. So this is, I think, I think we're coming back again. We manage this. So this is, then maybe I'll just talk a few words on prosthetic heart valves. Maybe, because that is where we lost a lot of patients. Maybe this is one point maybe I would like to share. This is from your British Journal of Obstetrics and Gynecology, your ACOG practice bulletin. It's very important for young obstetricians to be very well aware, because many normal pregnancy symptoms may look very much like a cardiac symptom. We need to focus on this. I am not focused on this because this is particularly available in your books. And Madam wanted me to talk about something about the beta blocker pregnancies. The time is, I think, getting more. I'll just talk about something latest. What about diuretic use in pregnancy? Previously, we didn't have any data. If you look at the 2000, you can see that no data available. Published literature, no published information. But now, thankfully, we have published information. I thought I'll share two of the very important published information with you. This is from the ROPAC data. 382 pregnancies with diuretics, of which furosemide was the most commonly used, 86%. And of these, what you find is, compared to no diuretic and diuretic use, the MACE was more, maternal mortality was more, thromboembolic event rate was almost similar. And the perinatal outcomes, you find that those patients who were given diuretics, the preterm birth was more, cesarean section was more, SGA was more. If you look at the predictors in the multivariable analysis, the use of diuretics was associated with the small for gestation age. What about congenital anomalies? Many of us are very concerned about it. This was not statistically significant increase. As you can see that the confidence interval crosses the neutral line. So this is not a statistically significant increase in congenital anomalies with diuretic use in the first trimester. So if there is a need be, we can always use it, but then we need to be very judicious. Another data came about beta blockers use in pregnancy. 875 pregnancies had beta blockers use, of which metoprolol and bisoprolol is the most commonly used beta blockers. As you can see here, beta blocker was significantly associated with small for gestational age. What about neonatal congenital heart diseases? Beta blocker use was associated with neonatal congenital heart diseases. If you look at the type of beta blockade, the incidence of preterm births and the incidence in the lower Apgar score was less with bisoprolol when compared to metoprolol. So of late now, for the cardiologist, bisoprolol is becoming a good alternative to metoprolol for use in pregnancy. If you look at the neonatal congenital heart diseases, again, it was little less with bisoprolol when compared to the others, but then the other medications in number was much, much less. What about the regurgitant lesions in pregnancy? They are very well tolerated. Moderate to severe regurgitations are well tolerated, except when there is LV dysfunction, when there is pulmonary hypertension or poor NOH class. Otherwise, they are generally well tolerated. And I'll finish up very fast and we can just be open to question answers. Stenotic lesions, as I told you, it's nice to do a balloon mitral valvotomy. In MMC, we do a lot of, but this is one case where we did a balloon mitral valvotomy in pregnancy. And this patient improved well and delivered well. And those patients, we presented this data in the European Heart Journal as well. This is one case where a balloon aortic valvuloplasty was done during pregnancy for a severe aortic stenosis. So basically the idea that what the obstetrician can know is that for severe MS, if it is a suitable valve, a balloon mitral valvotomy can be life-saving. So you will need to daily refer to a right center. And severe balloon aortic stenosis sometimes can be managed with a balloon aortic valvulotomy during pregnancy. This is one case done in Government Rajaji Hospital, Madurai. And last I'll just touch upon prosthetic heart valves. The safest for the mother is warfarin. Heparins do not cross the placenta, but it is very risky for the mother. The high risk of prosthetic valve thrombosis is safest for the baby. So the recommended management is, if the warfarin dose is less than 5 or acetram dose is less than 2, please continue warfarin. That is what is recommended. Even if it is more than 5 or more than 2, warfarin or acetram, the safest for the mother will be to continue vitamin K antagonists. And there are a lot of concerns about low molecular weight heparin. If we are using, we have to use only if we have the facility to monitor anti-10A levels. If we don't have the facility to monitor anti-10A levels, in a patient, a pregnant woman with the prosthetic heart valve, please do not use low molecular weight heparin. Please do not use low molecular heparin during pregnancy in a patient with a prosthetic heart valve if you cannot monitor the anti-10A levels. And these are the anti-10A level targets. During the second trimester, you can continue warfarin and aspirin. And then, it's very important when we transition, if there is a post-delivery, if the risk of bleeding is less, you can start transition 3 to 5 days. The low molecular weight heparin, again, a lot of people use low molecular heparin and we see a lot of complications related to that. These are the attractive alternatives, but the issue is that a lot of prosthetic valve thrombosis, subtherapeutic doses, inadequate monitoring, poor complaints. We always say low molecular heparin do not need monitoring, but there is one exception, that is during pregnancy. During pregnancy, low molecular heparin has to be monitored by your dosage. So this was one data of 800 pregnancies with the prosthetic heart valve between 18 publications. And what they found that is, this just to tell you that vitamin K antagonists are the safest for maternal composite outcome. If you look at the fetal outcome, if a high dose vitamin K antagonists, then heparin may be better. But here again, you have to remember that for the mother is always safer vitamin K antagonists. It's a low dose warfarin. Fetal outcome is equally as good as the low molecular heparins. So this is a risk chart to just tell you that. In our data from MPAC, we are not published yet. We find that we had 12 patients with prosthetic valve thrombosis out of 63. It's almost 20% of prosthetic valve thrombosis rate. It's very, very high rate. We really need to work on, but thankfully we improved this in this particular area. So I sincere thanks to each and every one of you who listened here. I was not too sure what exactly you needed, but this just I thought I share with you, and we can discuss anything you feel like, any questions you can ask.
Yeah, thank you, Dr. Justin, for this wonderful data, and we are really proud that we are able to go and show our data for the first time in the world history. This is very important because publishing a paper is very, very difficult. That too in obstetrics, this we are all always busy running around and publishing a data. Now it has become mandatory, so everyone is doing some paperwork, but yours is really to be appreciated and very much true because I know how much you have suffered.
It's a big teamwork.
I understand, but then you are the leader. We should appreciate, and we all will be with you, even the private obstetricians, everybody. And now they know cardio obstetrics, everybody is interested, and so many have joined in that WhatsApp group also. So now if there are any questions, it can be put in the chat box. And Dr. Karpagam?
Yeah. See, I just saw the chat box. There are no questions yet, but still I would set the ball rolling, sir. My first question is there a registry where everybody can access, every obstetrician can access?
That is a good question, madam. Is there a registry where access means would like to enroll patients? Is that what you're talking about?
Exactly. Because, so all of us do practice in different places and different kind of setups there. So basically, I just want to know, see, I've had recurrent atrial fibrillation in pregnancy. I've managed it quite well. So, I mean, we are with the team of cardiologists here. So if I have to compile, the data into as a registry for our statistics of our own epidemiological data for rheumatic acquired heart disease. So how do we go about this?
From data collection is very good. There is no doubt about that. But then to collect data, first we have to get a consent from the patient that we are collecting the data. And the rule is that we need to have an ethics committee approval for collecting the data.
Correct.
Now, if the private center, if you want to collect data and get an ethics committee approval, you need to visit the nearby institution where there's an ethics committee approval, and we probably will need to present all that. So at this point,
multi-specialty hospitals do have their own ethics committee and approval.
Yeah, that is fine. So if they have their own ethics committee, it is fine. Otherwise, it may not be possible unless we go and present it somewhere else and get it approved. And we also need to, generate a, good system to work on that. But I'll definitely take your point that because when we're presented by NPAC data, many people across the, South Asia and Asia, like, from Pakistan, from Bangladesh, from Malaysia, Singapore, they want to join the registry. This when we presented the NPAC. So, but then in this Indian data, we are doing India, but we are looking at a forum where any private obstetrician with a prior ethics committee approval can put their data in. But that is in the thought process. But then, we need manpower to, work on and interested people to collaborate. And that is one of the difficulties, madam. We really need people who can sit with us and work with us, or we need a team. That kind of team, if you can generate, we can definitely do something about that.
Don't worry, Karpagam sir has started this cardio obstetric society. We can all become the members.
Yeah, you're all. You just put the seed today. Actually, put the seed today, and we'll have a lot of advisors. Definitely, Foxy, Oxy, all will be advisory board members, and
Yeah.
we'll need inputs on that.
Kiran ma'am, do you want to share your views?
No,
ma'am?
I was just listening this discussion of data. Actually, this is a very good idea and at this platform you are discussing, because Indian scenario, this is the problem. We keep on working. We do manage so many patients, rare things, but we are not able to document them, or we are not documenting. Another thing, when the documentation, it should be in a format. It should be justifiable at the level of that race. So that is very, very important. Very nice points this has been brought about. And if Dr. Paul can definitely make help of it, then you are doing so much work, you can generate it. That's a very important thing. Otherwise, so like so many things, we are postpartum cardiomyopathy, we are identifying, we are saving the patients and differentiating, but we are not able to put them under. So if there is some format or something, then definitely, at least in medical colleges, we all have ethics committee, but then we can put it. So that's a good idea. I was listening to this. What should be the outcome?
Yes, Kiran. Yes, Dr. Kiran. Yeah, there are two questions in the chat box, Karpagam.
Yeah. I'll just so the first question is peripartum cardiomyopathy diagnosis, management, and recurrence risk.
Maybe I'll just take 2 minutes. I'll just present a couple of slides on this. This is, I think, I presented in Rajasthan Cardiology Society of India at Bikaner. 1 minute. So I'll just give you the points. Yeah. The diagnosis criteria is here. Onset of heart failure should be towards the end of pregnancy or within 5 months of delivery. So previously it was last 1 month, but many data now it's showing that 7 months, 8 months, we are finding it onset. And no other identifiable cause of heart failure. In LV systolic dysfunction, the ejection fraction less than 45. LV need not be dilated. Couple of differential diagnoses we always have. The patient may have a pre-existing cardiomyopathy, but generally they manifest at the 7th week, 28 weeks around that time, not towards the last week of pregnancy. 24th to 28th week is what they mean. And echocardiography will be able to identify all other issues. So this patient particularly, this is one data that shows that some of them of peripartum cardiomyopathy, Dr. LKM series, are outside the traditional timeline. And now management part of it is, if the patient is very unstable, we really need a cardiologist and the cardiology team to manage it. Once they manage it well, during the antenatal period, there are very few drugs that hydralazine, nitrates, beta blockers, and diuretics can be given. Whereas if they are stable in the postpartum period, if we can stop the lactation, the all good heart failure drugs can be given, like ACE inhibitor, ARNI, beta blockers, MRA, all can be given if we stop the lactation, because the ACE inhibitors and ARNI or MRA are not safe during lactation. ACE inhibitors can be given. And in very severe peripartum cardiomyopathy, we can give bromocriptine. The data is not very strong, but a large study called Rebirth study is ongoing in US and Canada at this point of time. But we will focus on that. Risk of recurrence, well, I think that was also asked. Then I think I had a couple of presentations and a couple of data is there about risk of recurrence. Let me check whether I have those slides here. The risk of recurrence depends on what shall I say, the presence of LV dysfunction. If the patient has LV dysfunction, residual LV dysfunction, the likelihood of worsening is much, much higher in those patients. In a patients without LV dysfunction, that LV function is recovered completely. I'm searching for the particular slide. Yeah, this is the one. This is the maternal complications associated with subsequent pregnancy. The risk of recurrence is going to be very high in patients with the non-recurring LV function. The mortality is very high and relapse is very high. In a recovered LV function, the risk is likely to be low, but it is not very low. It is still high. So what I practically do is that LV function should be good, normal, completely recovered. And we also do subclinical LV dysfunction identification by our strain imaging and stress echocardiography. Then we allow the patients to go through that. But still, we cannot say that the patients cannot worsen. There was a Scottish data that recently came in that showed that even patients who had improvement had subsequently worsened. The slides went through. So it is very important. We are very preliminary in our evaluation of peripartum cardiomyopathy. So much data is coming and coming, but we have to be very, very careful in advising subsequent pregnancy for a patient with peripartum cardiomyopathy, even though the LV function is completely recovered.
Yeah.
As long as the patient is a live child.
What is the role of cabergoline?
Well, the data on cabergoline is not that strong, ma'am, but you will be using it as obstetricians.
Yeah.
But for peripartum cardiomyopathy, there were a couple of studies, very few data published from. There was one registry in Hanover where they presented about 6 cases of cabergoline. They used only when bromocriptine was not available. In the Hanover registry in Germany, they have given this and they found that it was okay. But then, as you said, ma'am, the data is very, very limited and you cannot give dogmatic guidelines as to use. But then if you are going to use prolactin inhibitors, go for bromocriptine. If you don't have bromocriptine, you can use cabergoline. But at the same time, you have to really choose very, very sick patients. So the data shows that earlier you institute bromocriptine, the earlier the diagnosis is made, and if the EF is less than 25% or less than 30% with severe heart failure, those patients probably the benefit could be there. In reasonably stable peripartum cardiomyopathy, or peripartum cardiomyopathy, it is diagnosed maybe about 2 weeks or 3 weeks after diagnosis, the patient comes to you. Better not to institute bromocriptine.
The one more question, sir. This BNB, this is very, very new to the obstetricians. Is it a must that we should do BNB?
No, brain natriuretic peptide or NT-proBNP or BNP, as you rightly said, it is new to obstetricians. But it is available very easily in most of the laboratories, but not very thousand depending on the laboratory that we have. This gives us an idea of elevated filling pressures, and particularly in high-risk patients, it is very helpful in following up those patients. If the patient has a clinical heart failure, then it may not be really helpful, but then in early decompensation, particularly in patients with pulmonary hypertension or in patients with the borderline LV function, we use brain artery BNP levels to identify early decompensation. So recently we had a patient who wanted to have became pregnant actually. She was 8 weeks pregnant. She had severe pulmonary hypertension, but she wanted to have pregnancy. She was class 1, no symptoms at all. We got the BNP done, NT-proBNP done. It was 850. which means that she is not well, even though she says she is well. So we advise MTP in her the day before yesterday only.
So my question comes now here, sir. Now we have this WHO, MWHO, CARPREG program, Zahara program. Like those are kind of, maybe screening tests to identify even normal women who are absolutely asymptomatic to check for any impending cardiac diseases. Are there any screening programs where we can look at in the initial preconceptual phase or during the early pregnancy phase itself?
Can you say
There is a
one?
program, MW, there are scoring checklists, sir.
MWHO is a classification which
Classification
classifies pregnant women with heart disease into 5 categories.
yes.
Class 1, Class 2, Class 2 to 3, 3 and 4. And CARPREG is a scoring system that is scores based on the availability and gives a risk. And
Correct.
Zahara is a scoring system only for congenital heart diseases. And from India, a JIPMER team, my friend Dr. Anish and his team, they have published that Devi score for valvular heart diseases.
Oh,
And
okay.
we are developing a classification called MPAC classification. If for use in India, we classify only 4 categories instead of 5. The
Okay.
class 4 will be contraindicated pregnancy. Class 1 can be delivered anywhere. Class 3 will be to be delivered only in high-risk obstetric care centers. Class 2 centers can be delivered in moderate areas with even with the remote support of the cardiologist. So this may be practically usable classification in people like India, in countries like India and other devices. We are working on that. Now, in this background, if you can just put your question back, I'll answer you, ma'am.
No, that's what my question is, because now even the government is emphasizing on doing an echo during pregnancy for all pregnant women, isn't it, sir? So whether
There was a
even
question also in the chat box. When to do the echo?
When is the ideal?
the echo?
Good evening, sir. When is the ideal period to do a echocardiogram in a routine
The mother.
antenatal checkup?
Is it must, first of all?
Yeah.
For non-cardiac patient, we mean.
Asymptomatic, absolutely fine.
Now, I'll tell you, ma'am. I think, this is one of the study that I'll just, a commentary I had published in Journal of American College of Cardiology. I don't know whether you are seeing this.
Yes, sir.
So they had done a registry in Pakistan called pre-SAP registry, where they did a routine echocardiography for all the patients as a part of the study and published the data. And then I was called to write the editorial for this one. So I looked into all the studies available at that point of time, and some of them have done routine echocardiography by technicians. Some of them have done by obstetricians who are trained. This is a study from India. Obstetricians who are trained in baseline echocardiography, which is verified by remote echocardiography guidance and AI-based guidance and cardiologist-based routine echocardiography. All these things were done. Now, the point that we need to look at is the amount of energy that we put in and the diagnosis of the heart disease that we are catching up and the management changes that we are going to do because of echocardiographic detection. One thing we fail to do is that whenever we are doing routine, we are not doing a randomized study against a very clear clinical evaluation based selective echocardiography versus routine echocardiography. My personal advice will be a stethoscope cannot be replaced by echocardiography. Our echocardiography cannot be a replacement for a good clinical evaluation. AGOG has given a good red flags of identification. So if you do everything very clearly and then choose any doubtful cases for echocardiography, that will be the best strategy to conserve the healthcare infrastructure, health manpower. However, in the busy practice, we find that the obstetricians are overloaded with cases and they may not be able to spend that much time to routinely detect heart diseases. So as a result, now echocardiography is being advised routinely. Now, why are we doing echocardiography? Is it going to identify pre-existing heart diseases? Then anytime the earliest echocardiography will be fine. Even the first time the patient comes to us, we can identify by echocardiography, it is fine. But if it is to identify a peripartum cardiomyopathy, then the early echocardiography is not going to be helpful at all. We probably will have to do an echocardiography subsequently. So the advice that we gave at the end of this thing is, if your healthcare system can afford luxury of a routine echocardiography antenatally in the first trimester, that is always well and good. Because if we find something major heart diseases which will contraindicate a pregnancy, we can always advise MTP and then disease optimization and come back for a subsequent pregnancy. Otherwise, if it is going to compromise the care provided, say for example, if there have a cardiologist who routinely does about 150 echoes and he spends some time for managing the patient. Now you are going to load him with another 50 antenatal echoes. It is going to be at the expense of the remaining 150 patients of which the care may be affected. So we need to look at all that and then take a call. If the system has the luxury of routine echocardiography, please do it, but in the first trimester. But then if you're in the first trimester, you've done an echo, you may have to relook whenever the patient has a symptom subsequently.
Yeah.
What is the next?
One more question, sir. Prosthetic heart valve, how often PT-INR and echo to be done?
Echo again need not be done routinely. One echocardiography should be fine. And but definitely prosthetic valve patients, we always do an echocardiography because we don't really want to miss an increase in gradient. Now, PT-INR, we always advise to continue them as they were doing earlier, and preferably in already a patient who has a stable INR, but then pregnancy is going to alter the INR profile. So maybe once in 2 weeks initially, then if it's stable, once a month. But then if you decide to switch over to low molecular weight heparin with monitored by anti-10A levels or unfractionated, we will need to monitor more frequently anti-10A levels and then switching back to warfarins with vitamin A level, INR levels till it stabilizes, because stabilizing is going to take more investigation. So we don't hesitate to overdo PT-INR testing to ensure that we maintain a good INR. But I would like to share with you another information. We are a part of the ROPAC3 registry, and we just completed and we presented the data in the late breaking science in European Society of Cardiology. Across, I think, 34 countries, we collected 441 patients with the prosthetic heart valves. In MMC, we enrolled 34 patients. And the finding was, we were looking at the areas where more risk was there in patients with prosthetic heart valve. One of the risk predictors was more frequent INR monitoring. So whenever there is a more frequent INR monitoring, the risk was more. Probably we were just trying to explain more, but I'm just giving you this is for information. So probably more frequent INR monitoring, more frequent dose titration, and more frequent swings in the values, that could be a reason. So we have to, again, it's very vague data at this point of time. Still very strong data is necessary. All these data, if you look at the evidence base, is not very strong.
So one more question. Do we need to monitor factor 10A in regular antenatal checkup or only during labor?
For which patient you are talking about?
Any patient on low molecular weight heparin.
See,
which condition? Because low molecular weight heparin
prosthetic heart valves, because
prosthetic heart valve. Only in prosthetic heart valve you will need to monitor. If you're giving it for a venous thromboembolism prophylaxis or in a patient with pulmonary embolism and are doing it, then you will not need to monitor. If you monitor, that is fine. But then if you're doing it in a patient with prosthetic heart valve, it is a must to monitor anti-10A levels.
So this Dr. Surabhi has asked take-home message points on anticoagulation in pregnancy with valvular heart disease. So the same.
Anticoagulation pregnancy with valvular heart disease. The safest anticoagulation regimen for the mother is continuing vitamin K antagonist throughout the pregnancy, whether it's warfarin or acetrom. Now, if the dose of warfarin acetrom is not high, warfarin less than 5 and acetrom less than 2, please do not change to heparin at any cost. Only you should continue warfarin. Now, if at all you want to change between 6 to 12 weeks heparin, it should be only in patients with high VKA levels, with a clear discussion with the mother, telling that continuing VK is still safer for the mother, and maybe changing out to low molecular heparin may be safer for the baby. And then between 6 to 12 weeks, you can switch over to low molecular heparin monitored by anti-10A levels or intravenous unfractionated heparin, not subcutaneous unfractionated heparin. If you're giving unfractionated heparin, never give subcutaneous, it's always intravenous, and that monitored by APTT levels. And rest of the time, between the second trimester and third trimester, continue vitamin K antagonist with aspirin, and towards 36 weeks, switch over to unfractionated heparin. And then, by you plan the delivery, and after delivery, if it is not a very high bleeding risk, you can consider restarting vitamin K antagonist by 3 to 5 days, but restart heparin in 4 to 6 hours.
Yeah, bridging.
Bridge.
We bridge
After,
both. Yeah, we
after,
bridge both.
So which is better, acetrum or warfarin?
both are fine, man. Both are fine.
Okay.
Both are fine. I use more of acetrum. My colleagues, some of them will use more of warfarin. As long as the INR is maintained well, the availability well, I use acetrum because I find that titratability is much easier. 1 gram is available, 2 grams are available. Now 0.5 gram is also available. So that way, 3 grams is available, 5 grams is available.
One more question was there, no, sir? One more question is there.
Pregnancy with permanent pacemaker implantation, nothing needs to be done. It's a very safe condition. You can go ahead to the.
So we can use electrocautery during cesarean section if there is a permanent pacemaker.
If you are using if you are going to use an electrocautery, that generally should not happen, particularly as a bipolar cautery. Most of the time, you are using only bipolar cautery and you are keeping the plate behind. It generally does not do anything, but then definitely you can always ask the cardiologist to get the programmer and program it to a temporarily non-sensing mode so that it can be done. It is not a problem at all. If you can talk to the cardiologist locally, you can arrange a temporary change in the programming till when you're using electrocautery. But generally, bipolar cautery, the base, it generally doesn't do anything.
Thank you, sir.
Very interactive. I mean, that's a good point that the students have become very interested and they have asked so many questions. That's
So
very
infective endocarditis prophylaxis is a recent concept you tell.
Infective endocarditis prophylaxis, particularly,
Not needed for all cardiac disease. That is
definitely not at all. Definitely not at all needed. Depending on if you routine things, if you have a prostate, if you're aseptic, I think all procedures we are supposed to be doing aseptic only. So generally, you don't really need it. But then practically, we find that many of them are using it, and when we are formulating the CRF for NPAC, many of the obstetricians wanted us to collect data. So I was asking them, why do you want to collect data? When you collect more data, which we are not going to analyze as per because data we should collect towards the objective. This is not towards our objective. We are going to collect data. CRF is going to become bigger. We are overloading the data entry team. They said, no, we want more data on this because we need to see the practice patterns. I think we are collecting data on IE also in the NPAC database.
So now what is the current take home, sir? Ampicillin, is it? Ampicillin 1 hour before the procedure, is it?
1 grams before the procedure, and then
to be repeated only once after.
Repeated only once, and only in patients. Again, it is not routinely recommended. It is not routinely recommended.
Only for prosthetic valves. Okay, sir. I think we are done with
the 2 more questions are there. Just last option. Patient with chest pain in labor, but her previous echo was normal and her current ECG is also normal. What would be the next ideal step? Should we suspect MI in spite of normal ECG?
So generally, if the chest pain, what is the cause of chest pain? I think this is where we really need a support team. You get my point. We need to work together. When we are managing a patient, we need you and you need us. We need each other, and we need to have a good cardiologist with us to identify what exactly is the cause of chest pain. It's gastritis-related chest pain or musculoskeletal pain, it's a cardiac pain. If you think it's a cardiac pain in high-risk patients, definitely cardiac enzymes will help, cardiac biomarkers, troponin. The troponin is elevated, probably we can think in terms of a non-ST elevation, MI. But if the echo is normal and the ECG is normal and the chest pain is non-cardiac nature, it may not be cardiac. But we can obviously repeat another ECG another 4 to 6 hours and we can also have cardiac enzymes and cardiology consultations.
Sir, can angiography be done in pregnancy, sir? Angiography.
And yeah, and like, the patient develops an MI, we can do an angiogram. In fact, those of you who are here who are not aware of cardio-obstetric masterclass, we presented a case of acute MI during pregnancy from Hyderabad. The case was presented. We had a great discussion, and it is available as a video. Please Google cardio-obstetrics in YouTube. You'll find a channel called cardio-obstetrics, and you can. There are about 6 videos uploaded there. One video is acute MI during pregnancy, where this will be detailedly dealt with for an hour's time.
Okay. That's great, sir. Yeah. We will share, sir.
Yeah. Previously, whenever we get a case of heart disease, we used to get so scared whenever she was in labor. But now we are very fortunate, to have the video call, and many a times, we contact you, and through the video call also we have treated at ISO and KGH and MMC. So we are very fortunate to have this kind of a thing because the technology is being advanced.
Everywhere, I think the coordination between obstetricians and cardiologists are improving. We are so happy about that. And that is what my simple recommendation, wherever you are, get hold of your cardiologist, and if they are not aware of it, make them aware of it and tell them that you need to work together as a team, and call them to give a lecture in your department, and you go to their department and give a lecture. So that will be very helpful.
Thank you, sir.
Thank you so much, Dr. Justin,
Thank
having
you.
accepted and be a part of the obstetricians, and as a truly a sincere member of the Cardio Obstetric Society. And we will do wonders. We'll definitely go hand in hand, and we will give you all the data. And I'm sure Dr. Kiran ma'am, even in Foxy, we have to take this well forward, so that the entire nation will get the data for Justin Paul, and so that we can start. No,
you
sir.
have to have your data yourself. That's the
Sir,
fact.
you will be.
Yeah, it's our country which needs data,
Yes, I know.
basically.
Yes.
No,
Yes, thank
my
you, Dr.
recommendation
Justin.
is, madam, the thing is, everyone should, every doctor is also a researcher. So because you're all busy, if you just collect 10 cases, you would have seen 10 cases of pulmonary pregnancy. If you collect those data and present, it will be very useful for somebody else to do that. So just find some time to publish your data. That is all I'm telling you.
That's the most important thing that we all should
Yeah, that's
really
very
get into the habit of
important.
doing it, and we are so.
Yeah, and at this juncture, I am inviting everyone to be a part of Cardio Obstetrics
Cardio-obstetric.
workshop, which
Yeah.
will be as a
Annual
part of
conference.
our annual conference of Oxy. It will be on 23rd Feb on Sunday, and we will be doing together. The obstetricians and the cardiologists will be doing the workshop. All of you, please register. Thank you, Dr. Justin. Thank you so much.
Thank you.
Taking
Thank
your
you so much,
valuable
sir.
time.
Thank you.
Thank you,
I
Kiran
just
ma'am.
like to propose
Thank you, Dr. Vijaya.
thanks
for
from
a
on behalf of.
Yeah,
very
I'll call
nice
you for
and
the conference,
good
the annual
discussion.
conference. Yeah, I'll call you. Yes.
So on behalf of Oxy and Foxy, I extend my sincere thanks to Vijaya Madam, our President, Geeta Lakshmi Madam, our Secretary, Kiran Pandey Ma'am, Chairperson of Medical Education Committee of Foxy, and all the presidents and secretaries new of Foxy for this opportunity, and most importantly, Justin Paul sir for enlightening us about what we were seeing only the tip of iceberg. Now we know there's a huge iceberg underlying lying beneath what we have seen, and we need to really know in detail about how the entire physiology works, hemodynamics work, and how we have to tackle each and every situation and every cardiac case. Thank you so much, sir, and I also thank Shield Healthcare for giving us this platform. Sahiti for this platform. Thank you so much, Sahiti, and thank you. It was a very enlightening session, and all the data was really mind-boggling.
Yeah, very different. It's not like a usual lecture. With all the data and statistics, amazing.
Thanks to all the participants also.
Yeah, many, so many. I think medicine PGs also must have joined, I think.
Yes.
Okay.
Thank you so much.
Yeah, Kiran ma'am, all the best for your conference.
Thank you.
We'll see
Thank you
in
so